Hello guys, this is your Dr. Massman and today we are gonna study gastrology, a chapter in medicine, and let's start. Basically we have four layers: mucosa, submucosa, muscularis and serosa. So leave right now mucosa and serosa, just focus on two things: submucosa and muscularis. In submucosa, what is here? First of all, it has Meissner's plexus which has S and S in between. So let's take one more S and that leads to secretion, right? Then we have muscularis. Muscularis starts from M. So we have myenteric or orbic plexus in which what it does is motility or peristalsis, right? Also in submucosa, it is absent in gallbladder. Then we have ulcer, which is also called as Eppes ulcer or Schenker source. Okay, in this what we can see, first of all, it's benign, and its main characteristic is it upset the GI and also stress, and also it's painful, and its treatment is self-limiting, B complex or zinc, or we can give lidocaine or glycerin. Second is dental caries. It is the one which is most common in India. Okay. Then we have gingivitis. We can see what does it mean. It means inflammation of gums. It has entamoeba gingivalis, and its treatment is metronidazole. Right. Then we have leukoplakia, which is white in tongue. We can see color, and then we have many other stuffs also in this. We can see hairy leukoplakia. We can see candidiasis, which escaped away. Then we have leukoplakia, which is not scraped away. Then we have erythroplexia, right? So what these things are, this is sub uh, SCC of oral cavity. Okay. Then what we can see in SCC only, this is a cancer in which, see, we will start from in the body from oral cavity. Okay. For example, we have first oral cavity, then we have esophagus, then we have stomach, intestine and rectum. Okay. So in SCC, what we can see is it affects, usually this is a cancer which affects oral cavity, esophagus and rectum, only these three things. Now you will ask, what about the two things, stomach and intestine? So in this, the cancer which we have is adenocarcinoma. Okay. Now we come ahead, we have irritable bowel syndrome. Okay. In this, first of all, what are the symptoms, and then we see the other features. First of all, in this there could be abdominal pain, constipation, diarrhea, vomiting. Okay. And also it has the clinical features which we can see is defecation, which may improve or it may worse. Okay. In this there will be change in stool frequency, in this there will be change in stool form, and the best is stress or emotional symptoms we can see here. Okay. And the criteria which we have here is from 3 months to 6 months. Okay. In order to make the diagnosis. Okay. So these were two things which I told you. Now let's see ahead in the irritable bowel syndrome. Okay. So there are two things, constipation and diarrhea. So let's talk about constipation. What does it mean? It means it has less than 6 bowel habits per week. Okay. In this, in treatment, what we can give is fiber diet, Isofagula, Senna, Bisacodyl, lactulose and enema. So these are the things which we can give in constipation patient, right? Now comes diarrhea. So what's the infection? First of all, it's acute, 90% of the infection. In this, there could be E. coli, Salmonella, Shigella. In E. coli, the treatment could be fluoroquinolone plus or minus metronidazole. Okay. Second is ORS. Third is the best one, Resicadotril, which is anti-secretory. You might forget this, so that's why I am repeating it again. Resicadotril, which is anti-secretory. Fourth, which we can use, loperamide. So these are the 4 drugs which we can use in treatment of diarrhea. Now, in this, there could be a history. So what could be the history in this? There could be like dairy products. It could be from Staph aureus. Then it could be Chinese fried rice or noodles. And it could be infected by Bacillus cereus. Okay, cereus. Then comes traveling to Russia. There could be a case history of this. So it could be from giardiasis. Then it could be watery. In watery, it could be cholera vi puma. Okay, so all this history which is there, all this will be in less than 6 hours, right? Then in this we have one chart which the name of the chart is Bristol stool chart. Okay, and in this, one thing which you have to remember in seeing the aspect of Indian is the lacking fiber, which is type 5. Okay, which says that soft blobs with clear cut edges, right? So these are the things which we have seen in irritable bowel syndrome. Now let's talk about pseudomembranous colitis. First of all, it's antibiotic for long duration. Okay, and then in this there would be many other stuffs, but first we have to see which one is the common. So common is ceftriaxone. This is the common one, right? Second is potent. What will be the potent? See, both will started from C, but common one is ceftriaxone. Potent is clindamycin. Okay. Now comes the oral cause. The oral cause is amoxicillin. So this is the oral cause, right? So we have seen these drugs. Now let's see the treatment. In the treatment, it could be metronidazole, vancomycin, fidaoximine, but I would say fida, okay, in order to remember. And then it would be, fourth will be fecal transplantation, okay. Now in this, when we go ahead, we can see many other stuffs also. But let's see the Barrett's esophagus. Okay, first of all, where it is the most common site of lower 1/3 of the esophagus, which is in the GI junction. Okay, and it has a squamous metaplasia, or you can say metaplasia. Okay, so in Barrett's we have metaplasia, and squamous what we have intestinal type of columnar cells, which is goblet cells. Okay, and we have to also rule out adenocarcinoma. Okay, so these are the three things which we need to know about Barrett's. Okay, then we can see the varices. Okay, we need to see the picture of varices, and also we need to see the aberrant submucosal artery. Okay, and also we must know the Mallory-Weiss syndrome. In this we have Mallory tear. Okay, mucous tear, sorry. So where it will be present, it will be there in the alcoholics, which does the binge drinking. And then we have bulimics, right? So in treatment, it's only self-limiting. Okay, then comes ahead, we see, then we have watermelon stomach. In this we have GAVE, which is gastric antral vesicular ectasia. In this we have to rule out hematemesis, right? Then we can see foreign body, and then we need to know the candidiasis. Okay, so these are all the things which we have to see picture wise. Okay, we can get a VQ, visual question. Also we must know the Shiatsky ring. Okay, and then comes a syndrome which is known as Plummer-Vinzel syndrome. It is very important, and it has come many times in the exams also. So let's talk about it. In this we have triad. Okay, so first thing what we in this is post-cricoid web. Okay, second is iron deficiency anemia, and third it's glossitis, which is usually there in female. So these are the three things which we need to know. Let me repeat it again. Post-cricoid web, this which is there in dysphagia. Second is iron deficiency anemia. Third is glossitis. Okay, so these are the three things in Plummer-Vinzel syndrome. Then we have a corrugated appearance, which is feline esophagitis or hyper-eosinophilic. Okay. Then we can see FAP, familial adenomatous polyposis. So this can be a visual question, and in this there is a gene which is APC gene mutation at chromosome number 5. Okay, please remember 5. Okay, then we can see achalasia cardia. In this there is what we can see bird beak appearance. Okay, and then comes corkscrew. What is corkscrew? In this, first of all, the main thing is manometry. This you need to remember. Okay, in corkscrew both of appearances are little quite different. Okay, and in this there will be defect in the tone. So basically whenever we have corkscrew appearance, we have usually 5 things are there. Sorry, it's not for corkscrew, it's for manometry. For manometry we have 5 things: achalasia, okay, diffuse esophageal spasm, nutcracker esophagus, Jack-Hammer's esophagus. So these are the 4 things in which you need to do manometry, right? Okay, and then we can see the Barrett's metaplasia. In this we can see, like usually 1/3, 1/3 and 1/3. First is squamous cell carcinoma, second also squamous cell, third is adeno. So this is how we need to know, right? So let's go further and let's see the ulcer. Okay. So first we have peptic ulcer disease. In this we have two things: either it's peptic ulcer or it's duodenal ulcer, right? Whenever we have peptic ulcer, so in this what we can see is, first of all, peptic is the one which is less common. Okay. Second is it has hooped up margins, which is not regular. Okay. And the most important is the site. Where is the site of peptic ulcer? It is there in the lesser curvature, right? Then usually it's mostly benign. Okay. And the most important factor is when does pain occurs. If the pain occurs immediately after meal, that means it is a peptic ulcer disease. Okay. And in this, along with it, there will be a weight loss for sure if it is a peptic ulcer, right? And when it comes to bleeding, where will be bleeding? Bleeding will be left gastric artery, okay, in the peptic ulcer disease. And how do we see it? By endoscopy or biopsy, right? So it was all about peptic ulcer. Now let me talk about duodenal ulcer. Duodenal, it is the one which is more common. It has regular margins, okay, because the it is duodenal ulcer. So the word comes, like if we see the letters, duodenal starts from D, right? So its most common site will be D1, okay, and usually it will be benign, okay. And the which I told the most important factor of PUD, peptic ulcer, was pain comes immediately after meal, right? But here pain will be 2 to 3 hours after meal. So this is how you can diagnose it, okay, differentiating features. And in this there will be weight, either it will be normal or increased, but it will be no loss, right? And the artery, there it was left gastric artery, here will be gastroduodenal artery, okay, because it's duodenal ulcer, so artery will be also duodenal, right? And here we can see it by endoscopy. Treatment of both of them will be triple therapy, 2 antidote plus 1 PPI into 14 days, okay, clarithromycin or sorry, amoxicillin, okay. Now comes the things, like there could be some test, okay, either it could be invasive test or non-invasive test, right? So in this what we can see is, in invasive step it will be rapid urease, okay, histology and culture which we can see, but rapid urease is the one for the diagnosis, okay, which is invasive. And when I talk about non-invasive, it will be urea bear test. Basically remember just two things: if it's invasive, then it's rapid urease; if it is non-invasive, then urea bear test. These are the most important ones, okay. And in S. pylori, the test which is more common is the CLO test, CLO, CLO test, right? So now comes the malabsorption syndrome. In this, there are things. Mal means malabsorption, means less absorption. So what will the features? First of all, in this there will be no constipation for sure. Okay, there will be vomiting, diarrhea, steatorrhea, abdominal pain, micronutrient. Okay. Now let's come giardiasis on biopsy. Okay, you can see the VQ. Now let's come on the Whipple's disease. Okay, this is very important one. Okay, in this what you can see, you can remember it with word Whipple's, WHIPPLES. Okay, so from W it comes first is weight loss. Okay, H means hyperpigmentation, I means infection, Tryphema Whipple. ठीक है, WHI is done. Then comes P, polyarthritis. Next P is PAS plus macrophage in lamina propria. Okay, then comes L is loose stools. E means endocarditis, culture negative. Then S is steatorrhea. Okay, so these are the features of Whipple's. Okay, let me repeat it very rapidly. Once again: weight loss, hyperpigmentation, infection with Tryphema Whipple, polyarthritis, PAS plus macrophage in lamina propria, loose stools, endocarditis, culture negative, and steatorrhea. Okay, so these were the things. Now let's see a treatment. In treatment, what we can do is Merophena. So this is the treatment, Merophena. But you can remember like W, from the letter W. Okay, you rotate it, you will get a M. So Merophena, right? So this was the about Whipple's. Now let's talk about IBS. Okay, inflammatory bowel syndrome. In this what we can do is, first you have to see a diagnosis of exclusion. Okay, you can do endoscopy, stool test, biopsy, everything will be normal. Okay, now the main thing, how to know whether it is which disease or like how to differentiate it. So in IBS, what we see is abdominal pain. First thing, which is a must for sure, patient should be young, less than 45 degree. Sorry, 45 less than 45 age. Okay, young patient will be there, abdominal pain. Okay, and there will be change in stool consistency or either frequency, and also this is associated with defecation. Okay, so these all are the clinical features through which you can diagnose IBS, right? And also in this there are like three subtypes also, like IBS-C, IBS-D, IBS-M. C means constipation, D means diarrhea, M means mixed, right? And also maybe you can remember the drugs also, lubiprostone for IBC, IBS-C, okay? And if it is D, diarrhea, then you can use alocetrone, okay? Lubiprostone, alocetrone, okay? Now let's come to Meniere's disease. Okay, it's usually we have here is TGF alpha. Okay, in this there is formation of what? There is formation of rogue or folds. Okay, which is prominent folding. Okay, which lose enteropathy. Okay, and the treatment here is cetuximab. Okay, then comes FAP, which I told, familial adenomatous polyposis. Okay, in this we have gene. The number which I told you is APC gene number 5. There is 100% risk of colon cancer, which is classical one. Okay, so first we have is classical FAP. Okay, in this we have a prophylactic colectomy, which we do is because it's already 100% risk, right? Second is Gardner. In Gardner, what we have is polyp plus osteomas of jaw. Okay, this is second one. And third is Turcotte. In Turcotte, what we have is polyp plus gliomas. So these are the things which is there in FAP. Now comes Zollinger-Ellison syndrome, or this is also called as gastrinoma. Okay, in this, first of all, this is the most sensitive and specific one, and in this we have clinical features also. So first of all, where all these things are there. So first of all, it is there in the D1, duodenum part 1. Okay, and also it will be there in the pancreas, and also this will include confluence of bile duct. So there is a triangle in three of them. When you include all these three of them, you will get Zollinger-Ellison syndrome. Okay, in this what will be there? Diagnosis of Paraso or gastrinoma triangle, which is associated with Main-1 syndrome. Okay, so there could be a potential question of which one is associated with Main-1 syndrome. So you need to just mark it Zollinger-Ellison syndrome. Okay, so there could be clinical features. So what I told right now was the anatomy of it. Now let me tell you the clinical features. First of all, there will be increased gastrin, right? So whenever gastrin is increased, then that means there is also increased in the SCL. Okay, so whenever SCL increase, that leads to refractory peptic ulcer. Okay, so in this the treatment could be just PPI, the same which we can give, but importantly diagnostic. How do you diagnose it? You need to do endoscopic ultrasound. Okay, this is the investigation of choice of Zollinger-Ellison syndrome. Okay, now let's come to maltoma. What is this maltoma and what are the other steps? So all these things which we need to do here. This is a first of all B cell tumor. Okay, which is non-Hodgkin lymphoma, and also it has H. pylori. Okay, so this was about maltoma. Now let's see what is celiac spruce. I hope you guys know it, but let me just tell you it again. Okay, in this, first of all, the things which we have is, first of all, what is anti-TTG, anti-endomysial. So these are the two things which are there. And also in this, there is something called as bro, barley, rye, oat, wheat. So these are the four things, which is gluten sensitive enteropathy. Okay, in this there are villi, Krebs, all these things are present. So what we need to know is HLA-DQ2. This is the thing, and also we need to rule out whether it's a T cell, which is EAL. EAL is enteropathic associated lymphoma. So this we have to rule out. But with what this is associated? This is associated with type 1 diabetic mellitus, Hashimoto's, okay, Down syndrome, dermatitis herpetiformis, okay. And so this was the one which was associated. Now let me tell you what is the investigation of choice. Choice is villus atrophy plus crypt hyperplasia, okay, which is small intestinal biopsy. And what which I told you about bro, this is the one which you need to avoid it, because if after that, because there could be no improvement, okay, even after 2 months also, okay, so that's how this you need to avoid, okay. So maximum of the questions will be from like anti-TTG, anti-endomysial, bro, and what is gluten sensitive enteropathy, and also last they could ask is dermatitis herpetiformis, okay. So now let's talk about inflammatory bowel disease. In the bowel disease also, one question is fully expected, okay. So first is Crohn's disease and ulcerative colitis. Let's talk about what is first Crohn's disease, then we move forward to ulcerative colitis. In Crohn's disease, it could be from any part, from mouth to anus. First thing. Second thing is where is most common location. It will be in the ileum, right? Crohn's disease. And what about relapse? That does it relapse or it not relapse? So it has frequent chance of relapse. Okay. And where it will be? It will be mucosa, okay, transmural. So this is the one which will be there in transmural. Okay. Now let's see the antibody. So we have ASCA, ASCA antibody present in the Crohn's disease. Okay. And in this, what is there? There will be ulcers, which Eptha ulcer is the one which is the earliest here. Okay. In this, the smoking is bad. So there could be a question about smoking. Is it bad or is it protective? So it is bad in Crohn's disease. And there are some signs or some keywords specific. You just need to send directly ticket. So signs are string sign of Cantor, okay, creeping fat, okay, rose thorn, and cobblestone. So these are the 4 words for Crohn's disease. And in this, the treatment is steroids. Let's talk about ulcerative colitis. So colitis means colon, right? So usually it's there in colon and rectum. Okay, Crohn's could be from anywhere, but ulcerative will be from colon and rectum, and usually it's there in the rectum, and proctitis is the part. Like it's an inflammation of rectum, which is also called as proctitis, right? There it was frequent, but here we have less chance in ulcerative, less chance of relapse. Okay, there it was transmural, but here it will be submucosal or mucosal. There the antibody was ESCA, here it is PNCA or PSC, right? The most important thing is, does smoking is a protective factor in ulcerative colitis? Yes, this is the main thing. Okay. Also, it could be like the words which we use here is lead pipe colon. Okay. So these were all the things. Yes, and also let me tell you about the drug of choice. Here is 5-ASA or mesalamine. Okay. So this is the drug of choice of ulcerative colitis. So as I have told you, majority of the stuffs, and also you can see the other things. For example, in the Crohn's disease, it could be right upper quadrant pain. Okay, there could be fistula structures. In ulcerative, you can see hemorrhage, toxic megacolon or lead pipe, or malignant changes. So these all are the things which you can see. And also it has come in PG examination. In this, you can see treatment of choices. It could be mucosal polypectomy with ilioanal pouch anastomosis. This is for ulcerative. Now let's see the creeping fat appearance. You can see the VQ which is there in the Crohn's disease. Okay, creeping fat. And let's come ahead and see the rose thorn appearances, which I think already. You have studied already in the micro also. So rose thorn we can see. So these are also ulcers. So this is ulcer of which one? Crohn's disease. So Crohn's disease ulcer we have is rose thorn ulcer, which is rose thorn appearance. Then we have creeping fat appearance. This is also of Crohn's disease. Then we can see string sign of Cantor. This is also this Crohn's disease. And then comes this one, lead pipe colon or toxic megacolon. This is the one which is there in ulcerative colitis, right? And also which I told about cobblestone appearance. This is also Crohn's disease. So maximum of them are in colon disease, but Crohn's disease, but ulcerative colitis is the first food which you need to know is late pipe colon or toxic megacolon. Okay. Now you can also see which one is the pyoderma gangrenosum and erythema nodosum. Okay. Now let's see some up to the high yield points which I will tell you, which are most likely to come. Okay. In this, first the main thing which we need to know is the drug of choice of enteric fever. Okay, I told you guys enteric fever, right? So in this, the drug of choice is ceftriaxone. Ceftriaxone is drug of choice for enteric fever. Okay, and which one? Enteric fever on 4th week. Okay, usually it's there on the 4th week, and we have usually weeks about depending on the weeks we have divided. For example, in the first week we have is blood test. Okay, which is called as B. Then comes second week. In second week we have A, agglutination of Vidal test. In third one what we have is stool test. In fourth one we have is urine. So these are the four on which week what we do is, so that's how we do. So we called it as BASU, BASU, right? So now the third thing is aspirin can be used to prevent which cancer? If we use aspirin, so it will prevent which cancer? Which is a colon cancer, right? Then comes Zenker diverticulum. Okay, this is a benign or pre-malignant. So this is the one which is benign, right? And as I told, cobblestone appearance, this is seen where? In Crohn's disease, right? So let's see further some more points. Carcinoid tumor. This is if this increases. Okay, this has increased in urine. Okay, in what in urine? Usually they are. So we have 5H1AA. This is what we need to know. Now, most common site of carcinoid. Carcinoid most common site is bronchus. Okay. Question could be most common site of it. Initially it was carcinoid, so it was bronchus, right? Now most common site of GIST, that is stomach. Okay. Now a lady presents with IDA, malabsorption. So most accurate test. If a lady presents with IDA and malabsorption, so what would be the most important test? Small intestinal biopsy. Okay. Now sensory ataxia and patchy loss of papillae on tongue. If they are seen, sensory ataxia and patchy loss of papillae seen on tongue, then investigation will be B12 deficiency. Okay. If we have Cushing ulcer, where it is seen and why it is seen. Cushing ulcer means CUS. S is coming now. That means it will be seen in stomach, which also start with S, and also with the stress, which also start with S. There is a male with epigastric pain radiating towards back. That means acute pancreatitis. Okay. Rest I have told you. Let me repeat just more again in order to make you just fully confident with it. We have toxic megacolon. Where was it? Ulcerative colitis. Smoking is protective in ulcerative colitis. Barrett's esophagus causes what? Adenocarcinoma only. Remember I told you. Okay. Travers diarrhea is called by ETEC. Okay. You can also call it secretary, right? Now, just last thing which I would tell you is you need to know what is hematochezia, which is fresh blood in stool. Okay. So we have hemorrhoids or diverticulitis. So in adults, if we see which one is more, so hemorrhoids are more in adults. So we are talking basically about lower GI bleed. So hemorrhoids are the one which is most common in adults. And if we talk about children, so what will be there? Either rectal polyp or Makers diverticulum. So rectal polyp will be more in children. So see, diverticulum in adult also there was diverticulitis. Here also there is Makers diverticulum, but it's not most common. Most common is hemorrhoids or rectal polyp. Okay, hemorrhoids in for adults, rectal polyp for children. Thank you. I hope I have covered majority of the topics of medicine of this chapter, and I hope you like this. Thank you guys.